Hello there. So now we are going to study epidemiology, and we'll go topic wise. Let's jump right into it. Okay, so the first thing which we are going to start with is sensitivity and specificity. There is a table. Here are actually a few tables which can be very helpful in understanding both sensitivity and specificity. Uh, let's Now the cases where they actually test positive and the disease is also present, let's call them A, or these are true positive. Cases which test negative and the disease is present, let's call them C. These are false negative. B are the cases in which test is positive but the disease is absent. Therefore, these are false positive cases. Now the cases which test negative and the disease is also absent, these are true negative. I'm sorry for the disturbance. I think there is some construction work going on somewhere around. Please excuse that. Okay, so A are the cases which test positive and the disease is also present. So these are true positive. B are the cases in which test is positive but the disease is absent. So these are false positive. Now C are the cases in which test is negative but the disease is present. So these are false negative. D are the patients in which test is negative and the disease is also absent. So these are true negative. So what is sensitivity here? Sensitivity here would be A upon A plus C. That is the cases which are true positive divided by true positive plus false negative. Sensitivity correctly identifies those who are sick. Actually, here A plus C are the cases in which the disease is actually present. Whether they test positive or negative, that's another thing. So these are the total number of cases in which disease is present. These are true positive plus false negative. Sensitivity correctly identifies those who are sick. Now let's come to specificity. Now specificity equals to D upon B plus D. Here D are the true negative cases and B plus D, where B are the false positive cases and D are the true negative cases. So these are basically the cases where the disease is actually absent. Or we can write true positive upon total number of cases where disease is present. That can also be written.
A disease is a particular abnormal condition.
Here we can write specificity is equal to true negative cases upon total number of cases where disease is absent. I don't know why Siri is getting triggered. Now specificity correctly identifies those who are fit. Who are fit, or let's say healthy. Specificity basically is related to those individuals who are fit or who are healthy. So specificity is equals to uh, total number of cases which are true negative upon total number of cases where disease is absent. Disease will be absent in true negative cases as well as disease will be absent in false positive cases. It will also be absent in false positive cases. Now we have to read about positive predictive value. Positive predictive value is equals to A upon A plus B. Positive predictive value is basically equal to true positive cases upon total number of cases where the test has come out to be positive. So we can even write like true positive upon total cases where test is positive. Now, positive predictive value is the proportion of positives that are true positives. It is the proportion of positives that are true positives. Negative predictive value. Now, negative predictive value is equal to d upon c plus d. Or we can say true negative cases upon total cases where test is negative. And it is the proportion of negatives which are true negative. This is negative predictive value. It is equal to d upon c plus d. That is true negative cases upon total number of cases where the test is negative. Basically, this is important that sensitivity is equal to true positive cases upon total number of cases where the disease is present. Now, disease can be present in true positive cases as well as in false negative cases, which are falsely coming out to be negative, but the disease is actually present, so false negative cases. So it correctly identifies those who are sick, but yes, it will be having true positive in the numerator. Specificity is equal to true negative cases upon total number of cases where the disease is absent. Total number of cases where the disease is absent. It will include true negative cases as well as false positive cases, which are coming out to be falsely positive, but actually disease is absent. So specificity will have true negative cases in its numerator. Specificity, as it is having true negative in the numerator, so it kind of denotes or it correctly identifies those who are fit, because the test is coming out negative in them, those who are fit. Now, positive and negative predictive value. Positive predictive value is the proportion of positives that are true positive. Negative predictive value is the proportion of negatives which are true negative. So positive predictive value is equals to total true positive cases upon total number of cases where test is positive. Now, total number of cases where test is positive include true positive as well as false positive. Negative predictive value equals to uh, true negative upon total number of cases where the test is negative, which will include true negative as well as false negative. So these are certain important things. Now we will study about accuracy and odds ratio. Now accuracy, going by the same table, accuracy is equal to A plus D upon A plus B plus C plus D. So it is equals to true positive cases plus true negative cases upon
I didn't catch that. Could you try again?
total number of cases. Accuracy is the probability that a patient will be correctly classified, or it will be a truly positive or truly negative. So accuracy, it is the probability that a patient is correctly classified. That is, will be true positive or true negative. That means both the test and whether the disease is actually present or absent, they will be in accordance with each other. So it is the probability that a patient is correctly classified. True positive plus true negative upon total number of cases. Now odds ratio. Odds ratio is equal to AD upon BC. Odds ratio is equal to true positive multiplied by true negative upon false positive multiplied by false negative. So this is odds ratio. In the numerator it is true, in the denominator it is false. So true positive into true negative upon false positive into false negative. That is odds ratio. So these are certain calculation formulas here which we have to remember. First one is sensitivity, that is denoting the positive cases or the disease or the cases which are sick, correctly identifies those who are sick. So sensitivity is equal to true positive cases upon total number of cases where the disease is present, not the test is positive or not, where the disease is present. So disease will be present in true positive cases as well as in false negative cases, because they are coming out as falsely negative but the disease is actually present. Specificity denotes negative cases, so it correctly helps in identifying those individuals which are fit or healthy. uh, Now specificity is equal to true negative cases upon total number of cases where the disease is absent. Disease is absent. So disease will be absent in true negative cases plus false positive cases. It correctly identifies those which are fit or healthy. Now, positive predictive value. Positive predictive value is the proportion of the positives which are true positive. So it is equal to true positive upon total cases where the test is positive. So it will include true positive plus false positive. True positive upon true positive plus false positive. Negative predictive value is the proportion of negatives which are true negative. So it will be equal to true negative upon true negative plus false negative, or total number of cases where the test is negative. Negative predictive value is the proportion of negatives which are true negative. It will be equal to uh, total, it will be equal to true negative cases upon true negative plus false negative, or the total number of cases where the test is negative. Accuracy is the proportion of accuracy is the probability that a patient will be correctly classified, and it is the proportion between true positive plus true negative upon total number of cases. Probability that a patient is correctly classified or will be either true positive or true negative. So accuracy is equal to true positive plus true negative upon total number of cases. Odds ratio is equal to true positive multiplied by true negative upon false positive multiplied by false negative. Let's move on to the next. So always in such questions we have to draw a table, this table of the number of cases where the test is positive, number of cases where the disease is actually present, number of cases where the test is negative, number of cases where the disease is actually absent. So this way we can calculate all these things: sensitivity, specificity, positive predictive value, negative predictive value, accuracy, and odds ratio. By the way, the question here was that a new test called DIVE has been developed to identify DVT. In the study, 60 patients with positive DIVE have a confirmed DVT on ultrasound scan. So 60 patients having the test is positive as well as disease is present. These are true positive cases. 40 patients with a negative test had a confirmed DVT on ultrasound scan. These are false negative cases. 40 patients with negative DIVE had a confirmed DVT. 300 patients with a negative DIVE had an ultrasound scan excluded DVT. So these are true negative. 100 patients with a positive DIVE had an ultrasound scan excluding DVT. These are false positive cases. So in this way we can create a table, put all the values, and we can calculate specificity or sensitivity or anything: positive predictive value, negative predictive value, accuracy, and odds ratio. Now another question we have here is regarding the positive predictive value. So positive predictive value is equal to true positive cases upon total number of cases which are where the test is positive, or true positive cases plus true negative cases. True positive cases plus false positive cases, sorry, because it is the proportion of the positives which are true positives. So we have a table here. A study was performed looking at a new screening test. It is thought that this new test is able to detect breast cancer in those women who had a breast lump. Those who underwent the screening later had a biopsy as a gold standard test to identify breast cancer. Okay, so data has been given in the form of a table here, and okay, so test is positive, negative. So positive predictive value is equals to true positive cases, that is 300 patients which are here having biopsy positive, as well as the screening test is also positive, upon 300 that are true positive cases plus false positive cases where the test has come out to be positive but the biopsy results are negative, that is 200. So 300 upon 300 plus 200, that is 300 upon 500. So that is how we have to calculate. So 3 by 5 into 100, 30 by 5, 300 upon 500 into 100. So 300 upon 5, that is 60%. So as the question is asking for a positive predictive value, the only values we need to obtain from the table are true positive and false positive. Because we know the formula of positive predictive value, it is equals to true positive upon true positive plus false positive. Positive predictive value is a proportion of those who test positive that truly have the disease. Yes, it is a proportion of those who test positive that truly have a disease. Or it is a proportion of positives that are truly positive. Out of all the people who tested positive, which are those which are actually positive? That is positive predictive value. So here it comes out to be 60%. In this case, were confirmed to be malignant, that percentage is called positive predictive value. So we have to be careful for the tables that provide the last column as total, because this can be mistaken as the no cancer column. Sometimes it can be confusing and data could be wrongly taken and interpreted to use for the calculation. So we have to be careful about those columns indicating the total number of cases, because all we have to focus is true positive, false positive, true negative, and false negative cases. Now let's go to next topic. So there are 500,000 people who live in a town. In the past 5 years, there have been a total of 250 deaths in relation to a new strain of coronavirus. So they have asked about the mortality rate of this new strain of coronavirus in the town, expressed per 10 lakh individuals per year. That is what they are asking. So here we need to know about the mortality rate first. So mortality rate is the number of deaths in the population over a period of time. To calculate this, we first have to count how many deaths are occurring in a year. Because as a here in this question, as they have mentioned the total number of deaths in the past 5 years. So on an average, we can calculate how many deaths are occurring in a year by dividing the total number of deaths by the number of years. Next, we can calculate the mortality rate per 10 lakh individuals, or whatever is given in the question. Now the population we know. Now after knowing the number of deaths occurring in a year, we have to divide it by the total population of that place, and to express it in per 10 million, uh, per 1 million, or per 10 lakh, we have to just simply multiply it by that. The easiest way to count this is actually just to make the town have a population of 1 million, and we can do this by just doubling all the numbers. Okay, let's not complicate it. Let's just go by the simpler method. That is to know first, to know the number of deaths occurring in a year. Then divide total number of deaths in a year by the total population of the place. Now they can ask you expressed per 10 lakh individuals per year. Here they have asked per year, and they have asked to calculate the mortality rate per 10 lakh individuals. So we have to multiply it by that number. Let's say this be x, the number of individuals per year. So we have to just multiply it with x. Multiply it by x, and this will be in the question. Mortality rate is the number of deaths in a population over a period of time. First, we have to calculate the number of deaths occurring in a year divided by the population of that town. So it will tell the total number of deaths occurring in a year per individual, or which is expressed with respect to the population of the town. But we have to express it per 10 lakh individuals, so we have to multiply it by that number. Then we can calculate the mortality rate expressed per 10 lakh individuals per year. If they would have asked to express it as per individual per year, then just dividing the total number of deaths by the total population of that town would be enough. But because they have asked for a specific number, let's call it x, so we have to multiply this proportion with x to express it like that. Okay, let's one thing we have to write here, per individual per year. This will give this. Now let's move on to another topic. Here, a new screening test has been devised to detect early stages of prostate cancer. This test has been found to be positive in a high number of patients who are later discovered not to have the cancer on other more definitive testing methods. So, they have mentioned a new screening test here, and the question is regarding the positive or negative rate of that test, because test has been found to be positive in high number of patients which are later discovered not to have the cancer. So we are having a lot of false positive cases. So false positive cases are high in this case. So it will have a high false positive rate. The easiest way to remember this is by using the following definitions. True positive is the amount of sick people who are correctly identified as sick. False positive are the individuals amount, these are the amount of healthy people who are incorrectly identified as sick. Or false positive means they are falsely diagnosed as positive, but these are actually negative cases. They are not having the disease, but they are falsely diagnosed as positive. True negative are those, these are the healthy people correctly identified as healthy. False negative are those who are falsely identified as negative, but these are actually positive cases. These are sick people who are incorrectly identified as healthy. So a test with high sensitivity, as we know, sensitivity denotes true positive cases divided by,
I didn't get that.
as we know, the sensitivity denotes true positive cases divided by total number of cases where the disease is actually present. So it will include true positive plus false negative. So a test with a high sensitivity means few false negatives, because in that case true positive will be high, so false negative will be low. A test with low sensitivity means many false negatives. A test with high specificity means few false positives. Okay, here they are just talking about false cases. So if we are talking about just false cases, high sensitivity will have few false negatives. Low sensitivity will have high false negatives. Certainly, low sensitivity means high false negatives. High specificity will mean few false positives. High specificity. And low specificity will mean many false positives. So I think what's important is to kind of relate sensitivity and specificity. We can here have a look at false negative and false positives. So yes, we were studying about sensitivity and specificity of a test. So as we know, sensitivity denotes total number of true positive cases upon total number of cases where the disease is actually present. So it is telling about the true positive cases or the cases which are actually sick. Now, specificity, which is equal to true negative cases upon total number of cases where the disease is actually absent, or which is
I didn't
true
get that.
negative cases plus false positive cases where the disease is actually absent. So that is specificity. So it is telling about the negative cases, or it is telling about the cases which are healthy. But if we have to see false on the false cases, if we have to see the false cases, then we can simply say in sensitivity, or in a
I
case
didn't get
which
that.
in a test which is having high sensitivity, it will have low false negative cases. It will have low false negatives. High sensitivity means low false negatives, and high specificity means low false positives, because high true negatives, low false positives. As simple as that. And positive predictive value and negative predictive value we already know. Positive predictive value is the proportion of true positive upon true positive plus false positive, or the total number of cases who test positive. Negative predictive value is equals to true negative upon true negative plus false negative, or total number of cases which are testing negative. That is negative predictive value. And now in this case, as test is found to be positive in a high number of patients which are later discovered not to have the cancer. So patients which are having false positive, those are high. False positivity is high in this case. So high false positive rate. And accordingly we can calculate high and low specificity or sensitivity. We can even look at the false cases. High sensitivity means few false negatives. High specificity means few false positives. Low sensitivity means many false negatives. And low specificity means many false positives. So we can even look in terms of false cases. Even remembering the formula at the same time, we can use it to remember these things as well. Let me just quickly go through it once. Okay, let's move further now. Now here we have another question where we have to talk about the sensitivity of the test. Sensitivity, or what we say, is equal to true positive cases upon true positive cases plus false negative cases, or true positive cases upon total number of cases where the disease is actually present. So, a study involving a new screening test to identify a protein called LUN58 is being used to determine patients at risk of lung carcinoma. Following the test, lung biopsies are used as a gold standard to confirm the presence or absence of the lung carcinoma. So, we here have a table, same table, like we have to create the same table in each and every question. So, where the test LUN58 is positive and the number of patients uh, where the lung carcinoma has been confirmed by biopsy or not, those are given. So they have asked about the correct value which represent the sensitivity of the test. So true positive cases will be where the test is positive as well as the biopsy has turned out to be positive. So that is here 41 upon total number of cases where the disease is actually positive. So the disease is positive here where the biopsy is positive. So 41 plus 10 according to the table, or where uh, true positive plus false negative, we can say. False negative are the cases where test is turning out to be negative but the individuals are actually having the disease. So 41 upon 41 plus 10, that is 41 upon 51 into 100, that is around 80%. So sensitivity and specificity calculations are very commonly asked. Sensitivity indicates the individuals which are actually sick, or it measures the proportion of actual positives that are correctly identified as such. Sensitivity true positive, okay, specificity true negative. Sensitivity equals to true positive upon true positive plus false negative. Specificity equals to true negative, true negative upon true negative plus false positive. Because sensitivity equals to true positive upon total number of cases where the disease is actually present. So that is true positive plus false negative. And specificity equals to total true negative upon total number of cases where the disease is actually absent. So that will be true negative plus false positive. Okay, I think that's sufficient for these calculation formulas for now. Okay, let's move to the next. Here actually understanding the concept is very important. And just like this, we have positive predictive and negative predictive values as we discussed. That will actually include the, in the denominator, positive predictive value will include total number of cases where the test is positive. That will be true positive as well as false positive. And negative predictive value, true negative cases upon true negative plus false negative as well. Total number of cases where the test is coming out to be negative. Doesn't matter. And odds ratio we discussed, true positive into true negative upon false positive into false negative. And we also discussed accuracy, that is true positive multiplied by true negative upon total number of cases. A plus B plus C plus D. Okay, let's move to the next topic. So now we are moving ahead towards studies and controlled trials. So a study was conducted to look for associations between hard water and childhood eczema. Patients were selected and allocated into two groups by the method of computerized generated randomization. Group A had a water softener installed in their homes before the birth of their child. Group B was a control group, did not have any changes to their water system. Both groups were followed for 6 months with monthly follow ups and skin testing of the newborns. Researchers did not know which group the patients were allocated throughout the study. Researchers were not aware, they did not know about which groups the patients were allocated throughout the study. Now, they have asked about the single most likely study design here. So, what we have to study here is regarding the clinical studies. Let's go ahead and start with clinical studies. First, case series and case reports. These are the reports of cases and use no control groups or patient groups to compare the outcomes. They are similar to writing a report on a topic that you have read. So first we are studying about case series and case reports. These are simple reports of cases, and there are no any control groups or any study groups. There are no control groups or patient groups to compare the outcomes. These are the simple reports of cases, and these are similar to writing a report on a topic. Okay, now let's study about case control study. Now this is a study in which patients who already have a specific condition are compared with people who do not have that particular condition. So this is a study in which patients who already have a specific condition, they are compared with the people who do not have that particular disease or condition. And these study designs are observational, meaning that researchers study but do not alter what occurs. These study designs are observational. So the researchers study, but they do not alter what occurs. The researchers, they look retrospectively back in the past to assess if there was a significant difference in the rates of exposure to a defined risk factor between the groups. So these study designs are observational, meaning that the researchers study, but they do not alter what is the outcome or what occurs. They look retrospectively, that is back in the past, to assess if there was a significant difference in the rates of exposure to a defined risk factor between the groups. For example, a group A consisting of patients with lung cancer, group B consisting of patients without lung cancer. Information is collected looking at back at their smoking history. The hypothesis would be that smoking would incur a high risk of lung cancer. Group A with lung cancer, group B without lung cancer. Now they look retrospectively back in the past to assess if there was any difference in the rates of exposure to a defined risk factor between these two groups. So here information is collected regarding the smoking habit. Information is collecting looking at the smoking history, about smoking history, and what is incurred from all this. Hypothesis would be that smoking would incur a higher risk of lung cancer. This is a classical example of case control study. Smoking would increase the risk of lung cancer. So this is case control study. Case control study is a study in which patients who already have a specific condition that is their cases, they are compared with people who do not have that particular condition. So case and control. Patients who already have a specific condition are compared with people who do not have that particular condition. They can have other conditions, but they do not have that particular condition. So, case and control. These study designs are observational, meaning researchers study but they do not alter what occurs. Uh, they look retrospectively, that is, back in the past, to see if there was any significant difference in the exposure, in the rate of exposure to a specific risk factor or a defined risk factor between the two groups. So retrospective observation is done to assess if there was any significant difference in the exposure to a specific or defined risk factor between the two groups. Classical example, group A with lung cancer, that is cases. Control is group B without lung cancer. Now information is collected about their smoking habits, their smoking history. Hypothesis is formulated as smoking would increase the risk of lung cancer. So retrospective observations or retrospective study is done here to assess if there was any significant difference in the rate of exposure to a defined risk factor to come to the hypothesis. Between the two groups, if there was any difference in the rate of exposure to a risk factor. That is how retrospective study is done here. Okay. Now let's study about cohort study. This study identifies a group of people who share a defining characteristic. Now, this group is then compared with a similar group of people with the same defining characteristic. Cohort studies are purely observational and they may be prospective going forward in time or retrospective happen in the past. Because these studies are observational, the researchers, like in case control studies, they do not intervene with the groups of people. So here also, researchers do not intervene with the outcomes or they do not intervene with the groups of people as these are observational. Example of a prospective cohort study would be group A are patients who smoke, group B are patients who do not smoke. They are followed in time to determine who develops lung cancer. Now, what is the difference between a case control study and a retrospective cohort study? In Case control study, one starts with the outcomes and studies the exposure. Okay, we go back. One starts with the outcome and studies the exposure. In retrospective cohort studies, one already has determined the exposure but now needs to study the association of exposure to the disease outcome. Okay, so basically, pure retrospective study happens in case control because there we start with the outcome and we then study the exposure. Whereas, although these cohort studies can be retrospective as well, but here we have already determined the exposure, but now we need to study the association between the exposure and the disease outcome. Therefore, we have to go back. But we have already determined the exposure. But just now we need to study about the association between the exposure and the disease outcome, so we have to go back in that direction. That is why it is a retrospective cohort study. So that is the difference. So example of a prospective cohort study would be group A patients who smoke and group B are patients who do not smoke. Now they are followed in time to determine who develops lung cancer. So both of them are patients here. Look, these are a group of people who share a defining characteristic. What do they share? Both of them are patients here. It's not like case and control. Both are cases, but now they share a defining characteristic. So they have a defining characteristic. Now one of the group is of smokers, another are non-smokers, patients who smoke, patients who do not smoke. Now they are followed in time, that is in future, followed in time to determine who develops lung cancer. This is a classical example of prospective cohort study, forward in time. So it is also purely observational. Researchers do not intervene with the groups. Now, retrospective cohort study. Now, the difference between case control study and retrospective cohort study. So, what is the difference between these two studies? Because case control study, we know it is retrospective, but cohort study can be prospective as well as retrospective. So, in case control study, one starts with the outcomes and then and studies the exposure later. Whereas in retrospective cohort studies, one has already determined the exposure, but now needs to study the association between the exposure and the disease outcome. So what we can say in simple term is that case control studies start with patients in two groups, diseased
I
and
didn't catch that. Could you try again?
not diseased. Then look back in time to determine who was exposed to a specific risk factor. Retrospective cohort studies look into the past and take two groups, exposed and not exposed, and you look into the present to determine who has the disease. So, in case of a cohort study, let's just go through it once. Cohort study is a study which identifies a group of people who share a defining characteristic. This study first identifies a group of people who share a defining characteristic. This group is then compared with a similar group of people with the same defining characteristic. Cohort study identifies a group of people who share a defining characteristic. This group is then compared with a similar group of people with the same defining characteristic. cohort studies are purely observational. They may be prospective cohort study and retrospective cohort study. Prospective are forward in time, retrospective are backward, happened in the past. And here also researchers do not intervene in the outcomes with the groups of the people. Now, prospective cohort study example, group A patients who smoke, group B patients who do not smoke, both are patients. See, it's not like one is a group of patients, another is just a group of people without any disease. Both are patients. So they are compared and then they are further followed in time in future to determine who develops lung cancer. This is a case of prospective cohort study. Now, retrospective cohort study is how it is different from a case control study. In case control study, we first start from the outcomes of a disease. So we will start by taking two groups. One is diseased, one is not diseased. So we already know the outcome. One is having disease, another is not having the disease. So we start from the outcomes. And then we go back and study about the exposure of those two groups to a specific risk factor. So that is always retrospective. Case control study is always retrospective. Whereas cohort study, which can be prospective and retrospective, but right now we are just comparing the retrospective cohort study. In retrospective cohort study, we already know about the exposure to a specific risk factor, but now we are studying the association between the outcome of a disease and the specific risk factor. So we already know about the exposure of the risk factor. So in retrospective cohort study, we actually look into the past and we take two groups. One is exposed, another is not exposed, and then we look into the present to determine which has the disease. So it is kind of going forward, but that has already happened in the past. We have to look into the past. So in a case control study, we start with two groups of people. One is a group of cases that is diseased, and one is controlled that is not diseased. And then we look back in time to determine who was exposed to a specific risk factor. So it is retrospective. Now, in retrospective cohort study, we look back into the past. That is okay, fine. We look back into the past, but see, currently we don't know anything in the present time. We don't start with the outcome. We directly go back into the past and then take two groups. One is exposed to a risk factor, another is not exposed to a risk factor, and then we follow them into the present to determine who has developed the disease. So that is a difference between case control study and retrospective cohort study. In case control study, as the name suggests, we take two groups. One is of diseased, another is not diseased, or case and control, and then we look back in time to determine the exposure to a specific risk factor. So always retrospective. Whereas in cohort study, which is both prospective and retrospective, uh, in retrospective cohort study, we look back into the past, then take two groups of people. One is exposed, another is not exposed, and then we follow them into the present to determine which has developed disease. Which of them have developed disease. So this is retrospective cohort study. Cohort always moves in this direction, forward direction, but it can be retrospective as well as prospective. Cohort study identifies a group of people who share a defining characteristic. This group is then compared with a similar group of people with the same defining characteristic. Core studies are also purely observational. Okay, now let's move on to randomized controlled clinical trials. These are the experiments which introduce a treatment or exposure to study its effect on real patients. Randomized controlled clinical trials are experiments which introduce a treatment or exposure to study its effect on real patients. It usually compares an active group with a control group and employs methods such as randomization and blinding to reduce the bias. Typically, new drugs are tested this way. Example, a group of patients with disease X who meet specific criteria are randomly allocated to receive either the experimental treatment or controlled treatment, either the standard treatment for disease X or a placebo. Both groups are then followed in time and outcomes are observed. Example, a group of patients with disease X, group of patients with disease X who meet specific criteria are randomly allocated to receive either the experimental treatment or the controlled treatment. To receive either the experimental treatment or the controlled treatment. Controlled treatment can either be the standard treatment for disease or it can be a placebo. Both groups are then followed in time. Both groups are followed in time and outcomes are observed. So this is how a randomized controlled clinical trial works. These are basically experiments which introduce a treatment or exposure to study its effect on the real patients. These are the experiments which introduce a treatment or exposure to study its effect on real patients. It compares an active group with a control group, and it employs methods such as randomization and blinding to reduce bias. New drugs are tested this way. For example, group of patients with disease who meet specific criteria, they are then randomly allocated to receive either the experimental treatment or the control treatment, that can be standard treatment or placebo. Both groups are then followed in time and outcomes are observed. So randomized controlled clinical trials, these are experiments which introduce a treatment or exposure to study its effect on real patients. It usually compares an active group with a control group. It compares an active group with a control group and employs methods such as randomization and blinding so as to reduce the bias. So methods like randomization and blinding, they always come under randomized controlled clinical trials. Randomization and blinding so as to reduce the bias. These are important features of randomized controlled clinical trial. So new drugs are usually tested this way through randomized controlled clinical trial. An example is a group of patients having a particular disease who meet specific criteria.
I didn't catch that.
They are then randomly allocated. A group of patients having a particular disease uh, who meet a specific criteria, they are then randomly allocated to receive either the experimental treatment. One group will receive the experimental treatment and the other group will receive control treatment, that will be either the standard treatment or placebo, and both these groups are then followed in time and outcomes are observed. And this is done randomly. They are then randomly allocated to receive either the experimental treatment or the control treatment. So randomization can be done, blinding can be done so as to reduce the bias. Okay, so let's move further to cross-sectional study. This is a study which describes the relationship between diseases and other factors at one point in time in a defined population. and these are often used for comparing the diagnostic tests. They are often used for comparing diagnostic tests. A good example would be researchers performing a survey on a population to determine the relationship between increased levels of serum cholesterol and echocardiographic evidence of coronary artery disease. Both the exposure and the disease outcome are taken at the same point of time. It is like a snapshot of a population at a specific time. So cross-sectional study occurs in present time. It occurs in the current time. Here both the disease and exposure. Here both the disease outcome and exposure are taken at the same time. It is like snapshot of a population at a specific time. Another thing is systematic review. This focuses on a clinical topic and answers a specific question that arises. Meta-analysis. This is a study which examines a number of studies on a topic and mathematically combines the results to report the results as if it were one large study. Meta-analysis is a study that examines a number of studies on topic and mathematically combines the results to report as if it were one large study. So that is what means by meta-analysis. So these are the three things. First is cross-sectional study, which occurs in present time. Cross-sectional study is a study which describes the relationship between the diseases and other factors at one point in time.
Could you try again?
Cross-sectional study is a study which describes the relationship between disease and other factors at one point in time in a defined population. They are often used for comparing diagnostic tests. A good example would be researchers performing a survey on a population to determine the relationship between increased level of serum cholesterol and echocardiographic evidence of coronary artery disease. Both the exposure and the disease outcome are taken at the same point of time, and it is like a snapshot of a population at a specific time. So that is cross-sectional study. Now, systematic review. Systematic review focuses on a clinical topic and answers a specific question which arises. It focuses on a clinical topic and it answers a specific question which arises. Systematic review. Meta-analysis. It is a study which examines a number of studies on a particular topic and mathematically combine the results of all the studies to report the results as if it was one large single study. That is meta-analysis. Cross-sectional studies are used to compare diagnostic tests. Very important. It describes the relationship between diseases and other factors at one point of time in a defined population. It is used for comparing the diagnostic tests. Cross-sectional study is the one which is used for comparing the diagnostic tests, and it functions in present time. It's like researchers performing a survey on population in the present time, for example, between increased level of serum cholesterol and echocardiographic evidence of CAD. So both the exposure as well as the disease outcome are taken at the same point of time. It is like snapshot of a population at a particular time. And what we read about randomized controlled clinical trial was that they are experiments which introduce a treatment or exposure to study its effect on real patients. And it usually compares an active group with a control group. And it employs methods such as randomization and blinding so as to reduce the bias. So typically new drugs are tested by randomized controlled clinical trials. Active group with a control group. A group of patients with a particular disease X who meet specific criteria are randomly allocated. So a group of patients with disease X who meet specific criteria are randomly allocated to receive either the experimental treatment or the control treatment, which can be a standard treatment or placebo, and both the groups are then followed and outcomes are observed. So that is randomized controlled clinical trial for testing of new drugs. Cross-sectional study, which is for comparing the diagnostic tests. And systematic review and meta-analysis. Okay. So randomized controlled trials tend to introduce a treatment. In this case, it would be the water softener, which is compared with a placebo in another group. Another group, okay, so randomized controlled trials tend to introduce a treatment. In this case, it would be the water softener, which is compared with a placebo in another group, and both the groups are then followed in time and their outcomes are recorded. Whereas cohort studies, cross-sectional studies, and case-controlled studies, they are all purely observational, as opposed to randomized controlled trials where an experimental manipulation is involved. Single blinded trials mean either only the researchers or only the patients are blind to the allocation. In this case, it would only be the researchers, only since the patients would know that they are in the experimental group or control group based on the handyman's visit to the house to install the water softener. Okay, so here single blinding is done. Single blinding means either researchers or patients would know.
I didn't get that. Could you try again?
So yes, as we studied, patients were selected. Study was conducted to look for association between hard water and childhood eczema. Patients were selected and allocated into two groups by the method of generated randomization. So randomization is done. So we already know it is a clinical, randomized controlled clinical trial. So group A had a water softener installed in their homes before the birth of their child. Group B was a control group, did not have any changes to their water system. Both the groups were followed for 6 months with monthly follow-ups and skin testing of the newborns. Researchers did not know which groups the patient were allocated. So single blinding is there, randomized controlled trial is being done. Single blinding because patients or the groups would be knowing, because on the basis of whether water softener is being installed or not. Single blinded trial mean either only the researchers or only the patients are blind to the allocation. In this case, only the researchers are blinded because the patients would know if they are in experimental group or in control group based on the visit to the house to install the water softener. Randomized controlled trials tend to introduce a treatment. In this case, it would be the water softener, which is compared with a placebo in another group. Both the groups are followed in time, their outcomes are recorded. Cohort studies, case control studies, and cross-sectional studies are all purely observational, as opposed to randomized control trial, which are experimental manipulation, where experimental manipulation is involved. Manipulation done. Researchers manipulate to alter the outcomes. Now, one thing about cross-sectional study is that these are used for comparing the diagnostic test. It is a study which describes the relationship between a disease and the other factors at one point in time in a defined population. For example, researchers performing a survey in a population to determine the relationship between increased levels of serum cholesterol and ECG evidence, echocardiographic evidence of CAD. Both the disease as well as the exposure are taken, both the disease outcome and the exposures are taken at the same time. And it is like a snapshot of a population at a time, specific point of time. Okay, so let's take a break for a while and then we'll continue. Okay, so now let's move ahead. So here, uh, what is being asked is about the relative risk reduction. So a new drug called Zeper is undergoing clinical trials for the prevention of myocardial infarction in patients with type 2 diabetes. The trial looks at the incidence of myocardial infarction within a 5-year period. The following is the data. So they have given a table of the drug, experimental drug, and the placebo, and the number of patients who developed MI and the number of patients who did not develop MI. So they are asking about the relative risk reduction in this. So what we have to study here is risk reduction. Let's make a table first. Uh, Exposure, treatment group, non-exposure, that is the control group, disease and non-disease. A, B, C, D. So these are the people who were exposed to the treatment, but they developed the disease. These are the people who were exposed to the treatment and they did not develop the disease. These are the patients who were not exposed to the treatment or who were in a control group or placebo group and they developed disease. And these are the patients who were not exposed to the treatment or who were given placebo or who were in a control group and they did not develop disease. So to understand risk reduction, first we have to understand about the absolute risk. Absolute risk refers to number of events or number of cases of the disease in treated or control groups divided by number of people in that group. So absolute risk is equal to number of events of disease in a treated or control groups upon number of people in that group. Now absolute risk in control group will be equal to it is the absolute risk of events in the control group, which is equal to C upon C plus D. That is the number of cases, number of events of the disease in treated or control group on total number of people in that group. So here we are talking about the control group, therefore it is the absolute risk of events in the control group. It is equal to total number of cases of the disease upon total number of people in that group. Total number of cases, total number of disease, this is absolute risk of control group. So total number of cases of the disease or total number of events in the control group, that is C, because they are in the control group and they have developed disease, upon total number of people in that group. Total number of people, total number of people in that group, in the control group, will be C plus D. In the same way, absolute risk of treatment group will be absolute risk of events in the treatment group. So it will be equals to total number of events or cases of disease in the treatment group, that is A upon total number of people in that group, A plus B. Now absolute risk reduction will be equal to ARC minus ART, and relative risk reduction will be equal to ARC minus ART upon ARC. So we have to mainly focus on the control group here. That is a takeaway point. Absolute risk reduction is equal to absolute risk of control group minus absolute risk of treatment group, because this is the amount of risk which we have reduced by giving that treatment. So how much risk we have reduced? So earlier the risk was higher, but because of giving this drug, now we have reduced the risk, right? So risk reduction, absolute risk reduction will be equal to absolute risk in the control group minus absolute risk in the treatment group. Now absolute risk in the control group will be equal to number of cases of the disease or number of events in the control group divided by total number of people in the control group. Absolute risk of treatment group will be equal to number of cases of the disease or number of events in the treatment group, number of cases of the disease in the treatment group divided by total number of people in the treatment group. We know the absolute risk of both the groups, control group as well as treatment group. Treatment group is the one where we are trying or experimenting with that treatment, and we are trying to reduce the risk. We have reduced the risk. Now absolute risk reduction will be equal to, because risk would be higher in the control group where placebo was given, so absolute risk reduction will be equal to absolute risk of the control group minus absolute risk of the treatment group. Relative risk reduction will be equal to this with relation to the absolute risk of the control group. Relative risk reduction will be equal to absolute risk reduction upon absolute risk of control group. So it will be equal to absolute risk of control group minus absolute risk of treatment group divided by absolute risk of control group. So absolute risk, we have an example here. Treatment with the new drug, the patients who have developed it's a clinical trial, and the team develops a new drug which modifies cardiovascular risk factors. We assess the impact of taking this drug on the number of myocardial infarction in patients who have had previous MI or stroke. 100 patients are randomized to have the treatment, 100 are randomized to have placebo. So it is a randomized controlled trial. Participants were followed 10 years. Now, treatment with the new drug who developed MI 10 and who did not develop 90. Placebo who developed 20, who did not develop 80. So now we have to calculate the relative risk, all the risk, like absolute risk of the control group, absolute risk of the treatment group, absolute risk reduction, and relative risk reduction. Now, absolute risk of the control group is the one where placebo is given. So absolute risk of the control group is equal to number of cases of the disease in the control group, that is 10 that is 20, divided by total number of people in that group, that is in the control group, that is 20 plus 10, so 20 by 30, uh, 20 by 100, sorry, total number of individuals would be 20 plus 80. So the absolute risk in the control group will be equal to 20 upon 20 plus 80, that is 20 by 100.2. Now, in the same way, absolute risk in the treatment group will be equal to total number of cases of the disease or number of events of the disease in the treatment group divided by total number of people in the treatment group. So 10 upon 10 plus 90, that is 10 upon 100, that is 0.1. Now, absolute risk reduction, as we earlier, as we studied that we are introducing this treatment so as to reduce the risk. So earlier the risk was higher, so with the control group the risk is higher, so absolute risk reduction will be equal to absolute risk in the control group minus absolute risk in the treatment group. So ARC minus ART, that is zero point 0.2 minus 0.1, so it will be 0.1. Now relative risk reduction will be equal to absolute risk reduction upon absolute risk of the control group, that is absolute reduction, that is absolute risk of the control group minus absolute risk of the treatment group divided by absolute risk of the control group, that is zero point 0.2 minus 0.1 upon 0.2, so that will be 0.5. So this is how calculations are done for risk reduction. So again, just to go through the risk reduction once again, we first this table will be given in the question, or if data is given we have to make this table so as to simplify the things. So now this is the number of people who have been exposed to the treatment and have developed the disease, number of people who have been exposed to treatment have not developed the disease. So this is the treatment group, we have given treatment to them, some have developed disease, some have not. In the same way, we have a control group where placebo was given, some have developed the disease, some have not. So absolute risk is equal to number of cases of the disease or number of events of the disease in that particular group, in the control group or treatment group, divided by total number of people in that group. So absolute risk of control group will be equal to number of cases of the disease in that group, that is control group, divided by total number of cases in that group, C plus D. That is C upon C plus D. Now absolute risk of the treatment group, number of cases of the disease in that group, treatment group, divided by total number of cases, total number of people in that group, A plus B. So A upon A plus B. Absolute risk reduction, that is absolute risk of control group minus absolute risk of treatment group. And relative risk reduction, absolute risk of control group minus absolute risk of treatment group divided by absolute risk of control group. So relative risk reduction tells about how much the treatment reduces the risk of developing the disease relative to the control group. This is much more difficult compared to most of the other calculation questions. So relative risk reduction it tells about how much the treatment has reduced the risk of developing the disease relative to the control group, in relation to the control group. So first we have to calculate the absolute risk for each group, which we already know how to calculate, total number of cases of the disease in that particular group divided by total number of people in that group. Then we have to calculate absolute risk reduction and relative risk reduction. Okay, now let's move ahead. A double-blind study was designed to test the efficacy of a drug. One group of patients consisting of 898 people were given a placebo drug, and other group of patients consisting of 701 were given the active drug. Now, both groups were to be followed up for 1 year. Halfway through the trial, 25% of participants in the placebo group dropped out of the study, and 3% of participants taking the active drug dropped out of the study. What is the single best explanation? So, let me just go through the options once. Chance event or double blind study, failure of the active drug. So for some questions such as this, it is necessary to select an answer based on the process of elimination. So here we have options like it was a chance event, or it is explaining the failure of the active drug, or insufficient information to interpret the data, or an initial randomization error, and breakdown of the double blind study. So failure of the active drug is incorrect, seeing as how a more significant percentage of the placebo group withdrew. Failure of the active drug is incorrect. because 25% of the participants in the placebo group actually dropped out, and only 3% of the participants who were taking the active drug dropped out. So it is certainly not failure of the active drug. Insufficient information to interpret data occurs when researchers do not have sufficient results to analyze the study. Now, chance event in this context means that a specific cause cannot explain the people's withdrawal. That is, dropout was just by chance. The issue with this statement is that massive discrepancy in dropouts of the placebo group compared to the experimental group. An acceptable dropout rate between groups is considered to be less than 15%. Here we see a dropout rate difference of 22%. Furthermore, we would expect a dropout rate to be small, given that the study is only for 1 year. A study of 10 years may have a dropout rate of 20 to 25%, which is acceptable because patients are often lost to follow up as it is such a lengthy study. Dropouts not related to systemic bias could occur due to an unrelated illness, death, or job relocation. That being said, a study that only lasts for 1 year should have dropout rate that are near to zero for it to be considered a chance event. Then initial randomization error is a possibility, although the STEM gives no information as to how the patient was selected. If methodologies were not appropriate, it could lead to bias and compromise the study. The best answer here would be that there is a breakdown of the double-blind study. A breakdown in the study can occur if people from either group find out that they are in the experimental group or the control group. Patients in the placebo group may have found out that they have been taking placebo medication and hence decided to leave. This would result in a very high percentage of people in the placebo group leaving, which is precisely what we see in this case. Okay, so here we have certain facts which we have to remember. First is the breakdown of double blind study. It can occur if people from either group find out that they are in the experimental group or the control group. Now, patients in the placebo group may have found out that they have been taking placebo medication. So it may result in people dropping out. Or leaving the study. High percentage in the placebo group. Or it can also occur that if there was high percentage in the treatment group, then maybe that drug would have been having more serious side effects or undesirable for those individuals. So it depends basically on this question. And failure, if there is failure of the active drug, then more significant percentage of the people will withdraw. If failure of active drug, more people leave the treatment group or the experimental group. Now, chance event. Here, there are a few things to keep in mind about this. Chance event means that a specific cause cannot explain the people's withdrawal. The issue with this statement here is the massive discrepancy. Chance event, in this case, or in this context, an acceptable dropout rate between groups is less than 15%. It is acceptable. Dropout rates are smaller in short studies, that is for 1 year or so. So chance event in this context means that a specific cause cannot explain the people's withdrawal. Dropout was by chance. But the issue is that there is massive discrepancy in the dropouts here between the placebo and the experimental group. An acceptable dropout rate between the groups is less than 15%. Here it is differences of 22%. And we would expect a dropout rate to be small given that the study is only for 1 year. A longer study, like for example 10 years, can have a dropout rate of up to like 20 to 25%, which is acceptable because patients often they withdraw from following up in such lengthy studies. So dropouts not related to systemic bias could occur due to an unrelated illness, death, or job relocation. Another thing is initial randomization error, which is a possibility, although here no information is given how the patients were selected. If methodologies were not appropriate, it could lead to bias and compromise the study. So it is breakdown of the double-blind study which is occurring here, and it can occur if people from either group they find out that they are in the experimental group or in the control group or placebo group. It may result in people dropping out or leaving the study, and it occurs higher. There is higher percentage in the placebo group. But if there is failure of the active drug, then we will see more people leaving the experimental group. Now let's move ahead. A study involving a new screening test to identify a protein called ABLE55 is being used to determine patients at risk of breast cancer. Following tests, the breast biopsies are used as a gold standard to confirm the presence or absence. The initial studies have revealed the following results. Okay, we are again given a table. Now we have to describe the column as to what it actually represents. So 44 is they have given a table in which the test has come out to be positive and negative, and number of patients where breast cancer was confirmed, and another where it was not found on biopsy. So these 44 it is the number of patients who tested positive in the screening test, and the biopsy was negative, so they were testing, it was a false positive cases, they were false positive cases. I think we can resolve from this table. These are true positive cases. Disease is also present, test is also positive. These are false positive cases, test is coming out positive but the disease is absent. In these cases, the test is coming out negative and the disease is present. These are false negative cases. Test is coming out negative but the disease is present. False negative. These are test is coming out negative and the disease is also absent. True negative cases. That is what was asked here. And false positive is defined as a test that improperly indicates the presence of the condition when indeed the condition is not present. That is, test is coming out positive, disease is absent. Presence of the condition is improperly indicated when indeed the condition is not present. That's right. So the exam usually gives a scenario of a study whereby there are two tests to be performed. The first one is usually a screening test, and the second is a confirmatory test or a gold standard test. One is a screening test, another is a gold standard test or confirmatory test. So it indirectly indicates whether the disease is present or absent, this gold standard or confirmatory test. So confirmatory test is one which shows the absence or presence of the disease. These are usually biopsies like lung biopsy, cervical biopsy, skin biopsy, etc. So for the screening test, we will be given a table like this. Test is positive, test is negative, disease present, disease absent. So these are true positive cases. These are true positive cases coming up positive, but these are false positive cases. These are false negative cases. Test is coming out negative, but the disease present. False negative cases. And these are test is coming out negative, disease is absent. These are true negative cases. For example, let's say 10,000 people are recruited to join a study involving a new screening test to detect skin cancer. The new screening test is positive in 1,000 patients. So, test is positive in 1,000 patients. These 1,000 patients go to have a skin biopsy gold standard test. Okay, out of which 750 of them, as seen on the histology of the biopsy, have skin cancer. So, 750 are true positive, and the remaining do not have any evidence of skin cancer, but they were testing positive according to the screening test. So these are false positive cases. 1,000 minus 750 is 250. These are false positive cases. Now the new screening test, which was negative in 9,000 patients, were also followed up with skin biopsy. 8995 of the negative new screening test had skin biopsy which revealed no evidence of cancer. So these are true negative cases because they tested negative and their skin biopsy also revealed no evidence of cancer. Whereas remaining five had a skin biopsy which showed skin cancer, but they were testing negative. But instead, in reality, they have the disease because their skin biopsy is positive. So these are false negative cases. Okay, let's move ahead now. So the measure of dispersion of a set of values, standard deviation. The standard deviation is a measure of the spread or dispersion of a set of values or a set of observations, and it is calculated as the average difference from the mean value in the sample. So we calculate like one standard deviation, two, three, like that. It is calculated as the average difference from the mean value in the sample. That is important. Average difference between the mean value and a particular value. That is how standard deviation is calculated. It is a measure of the spread or dispersion of a set of values or observations, and it is calculated as the average difference between the mean value and the specific value, certain value in the sample. One standard deviation 68.2, two standard deviation 95.4, three standard deviation 99.7. Scattering of the values of a variable around the mean median of a distribution is dispersion. 68.2, 98, 95.4, and 99.7. One standard deviation 68.2, two standard deviation 95.4, three standard deviation 99.7. Okay, okay, let's move further. Half of a group of observations lies above this level, and it is particularly important if the distributions are not normal. So here we will study about median. It is the value of the observation that comes halfway when the observations are ranked in order. It is the value of the observation that comes halfway when the observations are ranked in order. For example, 2, 2, 3, 4, 9. So in this, 3 would be the median. So it is a value of the observation which comes halfway or midway. Is the value of the observation which comes halfway or midway when all the observations are ranked in order. That is median. Median is middle person. Mode is moody. Comes again and again. These are some mnemonics, like some terms, just to remember. A median is a value that comes halfway when all the observations are ranked in order. Mean is the average of all the numbers. Mode is the number that is repeated the most. The average of all the numbers. Mode is the number that is repeated the most. Mean is the average of all the numbers. Median is the number which comes midway or halfway when all the observations are ranked or placed in order. Mode is the number which is repeated the most, which comes again and again. Mode is the number which is repeated the most. Ranked order. Okay, so let's move further. A study was carried out in which 10,000 women participated. All the women underwent a cervical smear. 1,000 of the 10,000 women had a positive smear. Of these, 100 developed cervical cancer. 10 women who had negative smear developed cancer. What is the single most likely terminology used to describe the 10 women with negative results who developed cervical cancer? So, 10 women with negative results, and these 10 women who had negative smear, they developed cancer. So they were actually testing falsely negative because they were actually having cancer, actually had developed cancer, but their smear was negative. So these are falsely negative. A falsely negative is a falsely drawn negative conclusion, a conclusion that a person does not have a disease or the condition being tested when they actually do. Yes, false negative is a case where test is coming out to be negative, but in reality they are actually having the disease. The disease is present. False negative. Okay, let's move further. Study of a new drug to decrease the risk of myocardial infarction shows the following results. 100 out of 1000 patients on placebo drug developed MI in 5 years. 50 out of 1000 patients on the new drug developed myocardial infarction in 5 years. Now we have to calculate the absolute risk reduction. Now, as we know, absolute risk reduction, for that we have to first calculate absolute risks. Now, as in this case, we know absolute risk in the treatment group. One is the treatment group, one is the control group. Now, absolute risk in the control group would be the one which is having placebo. So, absolute risk would be equal to total number of cases which have developed disease upon total number of people in that group. So 100 developed MI, 100 out of 1000 patients. So 100 upon 1000, that is 1 by 10. That is 0.1. So that is the absolute risk of control group. And here the absolute risk of treatment group, or where the new drug has been included or which is being tried, is equals to number of cases of the disease upon total number of people in that group. So 50 developed disease, 50 upon 1000. Okay, that is 1 by 20 here. Okay, so 1 by 10 minus 1 by 20. So our answer would be 0.05, because we have to because absolute risk reduction is equals to absolute risk of the control group minus absolute risk of the treatment group. So it is first important to understand the meaning of absolute risk, which is the total number of cases in which disease has developed, total number of events in which disease has developed upon total number of people in that group. Absolute risk of control group, absolute risk of treatment group, absolute risk reduction is equals to absolute risk of control group minus absolute risk of treatment group, and relative risk reduction equals to absolute risk of control group minus absolute risk of treatment group divided by absolute risk of control group, that is relative risk reduction. Okay, let's move ahead now. Now in this case, a study was done to evaluate breast cancer using a mammogram. 10,000 patients were screened for breast cancer using a mammogram. 1,000 patients had an abnormal mammogram and had a further biopsy. Of those who went for biopsy, 100 of them had histology which showed breast cancer. 10 patients out of the 9,000 patients who had a normal mammogram were found to have cancer on biopsy. Which term best describes the group of 10 patients who tested positive on biopsy? Now it tells 10 patients out of those 9,000 patients who had a normal mammogram were found to have cancer. That means those 10 patients, their mammogram was normal. So the test was negative, but the biopsy actually showed cancer. So it was a false negative case. So there were 10,000 patients who were screened for breast cancer. 1,000 had abnormal mammogram who further underwent biopsy, and 9,000 obviously had a normal mammogram. So out of those 1,000, 100 of them showed breast cancer and 900 did not. And out of 9,000 who had normal mammogram, 10 had breast cancer and 8,990 did not. So we will definitely call them false negative, because is where the test incorrectly indicates the absence of the condition, in this case breast cancer. They have a normal mammogram, so their test is coming out negative. Test is not positive, but they are actually having the disease. So false negative, positive biopsy result. Okay, let's move further. Here we have 5,000 patients who were screened for skin cancer using new image recognition technology powered by AI. The new technology reported 500 patients had suspicious lesions. The new technology reported 500 patients had suspicious lesions, which on biopsy only 100 proved to be cancerous. Okay, and additional 5 patients who were not picked up by the new computer program to have cancer later developed skin cancer, which term describes the 400 patients who were negative on biopsy. Okay, so the new technology reported 500 patients had suspicious lesions. So, and which on biopsy only 100 proved to be cancerous. So, 400 out of them did not prove to be cancerous. They were, but they are, they had suspicious lesions. So they had suspicious lesions according to the new technology. So they were positive, but they were actually negative on biopsy. So it was false positive. These 400 patients were false positive because the test was showing them to be positive, but in reality, they are not having the disease. The biopsy is coming out negative, so false positive. So it is necessary to approach these problems systematically. The explanation below will explain the method of attack. The 500 patients who had suspicious lesions are all positive. These are all positive according to the test. All tested positive. This is always the case for the new screening method. It identifies all of the positives. Now the question is, are these positive patients true positive or false positive? The way to determine this is to use the gold standard technique, which determines the truth. That is, the gold standard always determines gold standard always determines if the result is true or false. For skin lesions, the gold standard is biopsy. In this case, biopsy determined that 100 positives were in fact true positives, whereas the 400 remaining were false positives. They were not having the disease, but they tested positive. So they were false positive. The 5 patients who later developed skin cancer are false negatives. They are negative because the screening method did not identify them as positive, and they are false because a biopsy later determined that they are cancerous. They were cancerous, therefore missed by the new screening method. So that is how we should approach these kind of questions. So two large groups of people. Now there is another scenario here where there are two large groups of people which are to be studied over a 5 years of period, over a period of 5 years. The first group, which consists of 450 patients, have been taking medication A. The second group, which consists of 550 patients, have been taking medication B. All 1000 patients are to be followed to investigate the outcome of the medications. Which is the single most likely study design? As here we know that we have to actually see whether this is a randomized controlled trial or it is a prospective cohort study. Now, a prospective cohort study assembles participants and follows them into the future. Cohort studies are observational, just like in this case, where the researchers did not offer the medication to the groups but found groups who were already taking these medications. So this is what's important and what can help us in differentiating it from a randomized controlled trial. In a randomized controlled trial, the researchers actually alter the outcomes by intervening. Whereas in prospective cohort study, as these are purely observational, the researchers do not intervene, so they do not alter the outcomes. So as we see here that the patients have been taking those medications, they were not given those medications by the researchers. So in that way we can conclude that it's not a randomized controlled study, it's a prospective cohort study. So as we studied, it assembles the participant and follows them into the future. These are observational, where the researchers did not offer the medication to the group but found groups who were already taking those medication, followed them. The medication in this case is the factor that is being studied. After the baseline information is collected, the participants are then studied over a period of time for their outcome. Now distractor here can also be another thing, that is a prospective case control study. A case control study is used to usually describe a retrospective study. Since the study starts with the identification of the participant with the disease, so we already start with the outcomes with the disease, without the disease, not like retrospective cohort study where it starts with the exposure although it is retrospect, but starts with the exposure to the risks. So exposed and non-exposed there. In case control, we have diseased and not diseased, and with the identification of the participant with the disease, that is case, and comparing it with a reference group, that is control. This is termed as prospective case control. Sorry, this is termed as classical case control study, which is retrospective. But there is a term called prospective case control, but it is still retrospective. A prospective case control is one where new cases can enter the study as it is diagnosed. Nonetheless, it remains retrospective since it looked backwards in time from the outcome to find its cause. Remember that a case control study would require the case, which are the people who have the disease. Remember that a case control study would require the case, which are the people who have the disease. In the study in the STEM, there are no groups with the disease. Yes, here we have no groups which are having the disease. We are just following two groups who are taking medications. We don't know anything about the outcome of the medication. So, case control study will always include a group which is of cases, that is, of the patients who are having the disease. But here it is not the case. Now, randomized control study trials. Randomized control study would be applicable when the researchers have already altered a group. They have altered a group. For example, if the researchers randomized two groups and chose to give a specific group a particular medication, that would be a randomized control trial. That is not what's happening here. So, few important things to note here. One more important thing is that a case control study always have a group of patients with the disease. Another thing to focus So a prospective cohort study uh, assembles the participants and follows them into the future. Cohort study can be prospective and retrospective, but a prospective cohort study assembles the participants and follows them into the future. These are observational, where researchers will not offer any medication to the groups but found groups who are already taking the medication and followed them. Medication is the factor which is being studied. Okay, for their outcome. Now, there are certain studies, or there is a term called prospective case control. Prospective. Usually, case control studies are always retrospective. Technically, this prospective case control is also retrospective. Term used because new cases can enter the study as it is. New case can enter the study. New cases can enter the study as new case, single case, as it is diagnosed, but still retrospective as looked back in time from the outcome. So, a case control study would always be retrospective. It starts from the outcome, that is case and control, disease and not diseased, and then we go to the exposure or to the risk factors. Exposure to the defined risk factors. Whereas in cohort study, prospective cohort study, follow assemble participant, follow them into the future, then study their outcomes. Whereas retrospective cohort study, we go back in time. We start, we go back in time. It is retrospective, but we start from the exposure. That is, we start from the exposed and non-exposed, and then we go to the outcomes. So that is the retrospective cohort. Prospective case control is still retrospective. In this, new case can enter as it is diagnosed. New case can enter the study, but it is still retrospective as we are still looking backwards in time from the outcome to find its cause. So this is it for today. This is for this session, and see you next time. Till then, take care of yourself.